Randy Bach. I'm here today with Knut Wittkowski. He's a biostatistician and epidemiologist, previously from Rockefeller University, and he has shown integrity through the COVID pandemic. He stands by his words. He has not flip-flopped, as many have. Knut, can you tell us a little bit about your journey, what your views have been, whether they were accepted, controversial? How does it feel, from this perspective now, having seen the way things played out?
I'm not surprised, and I expected that what I said would hold true, because I'm very careful. I never say anything where I don't have good support from the data, and I understand the epidemiological theory. So I've been teaching theoretical disease epidemiology for 35 years. And there are very few in the discussion who actually have a comparable experience. And so I was very sorry for people that whatever I said was mostly criticized. I was shut down by YouTube. I was criticized by the Rockefeller University for actually doing something reasonable. It was a very hard time. And then in 2020, I had quite a number of interviews and appearances. Now we have published the things, but now there is very little interest in the media, in part probably because I don't change my position all the time. So there's never anything new in what I say. It's mostly the same thing I said 3 years ago.
Okay, can you tell us the essence of what you did say 3 years ago?
I said that we had coronaviruses before, many times over the last 100 years, except that we couldn't sequence the virus. But this is how coronaviruses became, some of them became cold viruses. They used to be flu, and then they mutated and became colds. So it was nothing new, except that we saw from the genetic testing that it was not an influenza virus. And so everybody got scared, and the situation in Italy was not helpful. But then Italy is the oldest country in the world, maybe next to Japan, and maybe the Vatican State.
Right, so, as far as demographics of the individuals.
Yeah, the demographic is bad, and the health system in Italy is also not one of the most stable in the world. And so there were a couple of reasons that the epidemic looked very bad initially in Italy. But other than that, there was no, we have seen that initially in China, then in Korea, and in Italy, that this epidemic does exactly the same thing all other influenza or respiratory virus epidemics do. They come, they peak, and they end. And the whole thing within a couple of weeks. So what we knew was that this epidemic is no different from other epidemics. And we knew that from before the virus actually was recognized in Seattle in the United States in 2020. And it was confirmed. So what we have seen in New York, in the epicenter of the epidemic in March 2020 and early April 2020, what we have seen was a very normal course of the epidemic. And so there was actually and I remember that very well, On April the 17th, 2020, there was a meeting at the White House. And of the people participating, both the president, or all three of them, the president, the vice president, and then the director of the CDC, they all three advocated that the country should reopen. Redfield, the director of the CDC at that time, he said, we have all the reporting tools in place. We have hundreds of people here at the CDC standing ready to deal with the epidemic and help out all the states who might have a problem. So we are prepared, we can reopen. So the three most important and also knowledgeable, at least one of them was one of the most knowledgeable people, advocated that the country should reopen in April 2020. And it didn't happen. And until today, I have no explanation. I haven't seen any reasoning why the country was not reopened. Just remember, the lockdowns were supposed to be for 3 to 4 weeks to just prevent a spike from getting too high and overloading the hospital system. And after that period of 3 to 4 weeks, the lockdowns were expected to end. And at the White House, the decision was made, or at least the opinion was voiced by the main leaders that the lockdown should end, but they didn't. Why? You tell me. I have no clue.
Well, I think there was, I mean, I don't know why the president didn't preside adequately in that. I think that there was, you know, he was at somewhat of a deficit, not being medical. I mean, that we don't have a medical, I don't think we've had a medical president. I think Rand Paul ran once, but, and Ron Paul, I don't know if he was a physician, but the concept, you know, is always going to be that, you know, the health people are going to take over. But I think this is a mischaracterization of what public health has been and should be.
But Robert Redfield, the director of the CDC, the Centers for Disease Control and Prevention, was, from his experience and his position, the most important person in the room. Mm-hmm. And Robert Redfield advocated reopening because the CDC was ready to deal with all situations that might come.
Yeah, so I mean, we'll have to go look at that separately. So, I do you have a theory about that? I mean, and what did happen, and how did you, you know, enter into the conversation?
Well, I published in late March a paper in the same publication organ where the two British epidemiologists had published before, which was Niels Ferguson and Sunetra Gupta. Mm-hmm. And so I published in the same organ in medRxiv. I analyzed the dynamics of the epidemics that we had seen so far, including in China, in South Korea, in Italy. And I concluded that what the government should do is to isolate the nursing homes, like it was very successfully done in South Korea, and otherwise keep the economy and the schools open.
I agree.
And somehow that was apparently misunderstood. So the government kept the nursing homes open and closed the economy and the schools.
And it makes no sense at all. I mean, you know, I'm curious,
that makes sense.
I'm curious how much and to what extent you also looked at the Diamond Princess, which I kind of see as a perfect, you know, almost like a laboratory experiment. If you know, you couldn't, it would cost you $10 billion after the fact to get 3,700 people on a boat and spread coronavirus when it was unknown and so forth. But at the time, the median age of death, there were 11 deaths out of the boat after a few months, and the median age was 82, and that was pretty much duplicative of other places, including the U.S. and Italy and whatnot. That it was, it's a sad thing. Nobody wants to get the influenza. Nobody wants to get coronavirus, so forth. But old people do die. 45%, I think, of the deaths were nursing home quality or lack of quality individuals. And if you're in a nursing home, your life expectancy is about 13 months in 2019 and 2018. And it might have changed a little bit in 2020. But, the real bulwark against passing infections around historically with colds and flus and whatnot has been that the mobile population, who's not going to really, exhibit severe illness or death from this, they go around and they basically become the fortress against the continuation of the virus. So the first question is, A, do you count the Diamond Princess as a reasonable experiment? Do you look at that at all? Would people ignore that? And then B, does that align with your views, kind of the forming of like a fortress for the old elderly and so forth, if younger people can build up immunity themselves?
I have to say I've never looked that much into that ship. What you just mentioned was there were a large number of high-risk people on board, and of them, very few died. And vulnerable people are dying of respiratory virus disease infections is nothing new. It happens every year. Every year in the United States, between 35,000 and 65,000 people died from the flu. And that's just normal. And nothing to be scared about. And nobody before came up with the idea to shut down the economy because of the vulnerable elderly. It's not just enough to be old, you also have to have several comorbidities, as we learned in Italy. Of those very vulnerable people, some will die, and that is unfortunate, but natural.
So you said you didn't flip-flop. Have other people flip-flop? When you look back, you and I were chatting before this, and there's an article in the Wall Street Journal that quotes the article from the Lancet, very recent vintage, that they're kind of coming to the realization natural immunity works. It's presented stronger, broader based immunity to all the variant strains in the original ancestral version as well. Have people flip-flopped as a result of this, and whom do you see, or who do you see as having done that?
Okay, you mentioned just one case. The New York Times very recently flip-flopped. So suddenly they acknowledge natural immunity and they question the effectiveness of masks, which is something that they haven't done for 3 years.
Well, I just want to
another example.
One little caveat on that. That was an op-ed piece by Bret Stephens, and he's the resident non-leftist at the New York Times. So I don't think it was the house organ itself or the chief science writers at the New York Times per se, but they did allow the piece in, which is different for them. Ordinarily, they keep a pretty strict rule about what type of things, even from their non-leftist op-ed writers, opinion writers.
I mean, for 3 years, the New York Times has been mostly a spokes organ for the government. So they haven't done what newspapers, I think, should do, and that is to question the government and ask for explanations. It never came, at least I don't remember it ever coming from the New York Times. But the New York Times was not the only newspaper. I think all of them were more or less the same. Everybody felt, for whatever reason, that the government should not be questioned, even if, and you mentioned flip-flops, the government was flip-flopping, or at least Fauci, for instance, was flip-flopping several times. Just to think about masks. Initially, he said nobody should wear a mask. Then he said we should wear a mask, not because it does anything to the epidemic, but of a sign of our willingness to participate in fighting the epidemic. Then masks should be worn until there is a vaccine. And when the vaccine was there, we should wear 2 masks on top of each other. This was all one person speaking for or advising the government. I don't see a lot of consistency there.
No, nor do I. I think a lot of this, the word, public health, publius is Latin for the people, basically, the public. And I think, and it's also the same word as politics. And I think that a lot of politics, it goes into public health, and we shouldn't ignore that. I think that's not a bad thing, because we don't want to be governed by a diagnosis. We shouldn't all stay indoors because monkeypox is a bad diagnosis if you happen to have it. There has to be a political equation, which balances the needs of the people who might have monkeypox versus everybody else who needs to go to work or whatever the illness, or RSV or whatever it happens to be. There always has to be an equation and a kind of a balancing of what it is. And I can understand, if we had the equivalent of respiratory anthrax, going around, if anthrax, whatever, that maybe there should be some certain mandates or whatever. But there was always a disproportionate aspect to this most recent pandemic, and the shouting down of opposite voices, I think, in part contributed to the perception that they were overdoing things. So the question I have for you is, where did your paper get you? What happened with your name and voice, and were there people persuaded, and what's been the result? What's been your path from that and since that?
Some people got persuaded, but it doesn't have the response that would actually have an influence to correct some of the things that went wrong. And part of it is that the philosophy here was to shut down any discussion. No scientist was allowed to ever have an opinion that deviated from the current opinion of the government or the WHO, whatever it was people were referring to. Mm-hmm. And that was considered science, when in fact the very nature of science is that people discuss to find the best solution for a problem. And that would have been particularly important in a situation like this, where we were faced with the proposal of interventions that had never been tried before. There had never been a lockdown. There were certain areas like Wuhan were isolated. So isolating those who are cases, real cases, those who have symptoms, isolating those who are cases and might spread the disease to others, is a very well-tested strategy in epidemiology. But here we isolated the whole population, the healthy people. The healthy people were never isolated. There were never restrictions on the healthy people. So it was something entirely new, and yet it was never discussed because the discussions were blocked.
So where did this concept come from? I mean, it must have been written about or or been part of some, pandemic war game or whatever, where did the concept go? What has been written, what had been previously written about lockdowns and so forth in the epidemiologic literature before 2019, say?
Nobody had, to my knowledge, nobody has ever even considered a lockdown. It was something that arose in Italy. So initially, the situation in Italy looked very bad. Lots of people died, and that wasn't clear yet. That was only a few weeks later. It wasn't clear yet that only those people died who were old and had at least 2 severe comorbidities. So initially, it looked very disastrous, very dangerous.
Mm-hmm.
And so the Italian government, in its need to do something, perceived need to do something, they started lockdowns. And to the surprise of everybody, people did not revolt. People did accept it. And so there was suddenly a new tool around that politicians could use. And so everybody found something they could use that tool for. And so it was used extensively. But there was no evidence that it does anything good in terms of epidemics. None. It had never been tried before. And it was also not done in a fashion to actually try to find out whether it might work. So all the strategies that scientists have to answer questions, like saying, okay, let's do a lockdown here, and then we have another city that is comparable, close by, and there we have no lockdown, and then let's see what happens.
Mm-hmm.
That type of comparison was never made. So there was no evidence around that would help to justify doing something that had never been done before. And that is even though in medicine, the major guideline is first, do no harm. And every intervention carries the risk of doing harm. And the lockdowns did a lot of harm. Some of it was obvious, they cost a lot of money. But others were not so obvious, were known to epidemiologists, but epidemiologists were never being asked. Let me talk for a brief moment about the negative effects of lockdowns. The first is something that we were not allowed to say very early on. A respiratory virus disease ends when we have herd immunity. That word was not allowed to be used. Although it's in epidemiology, this is what it is. And today we can use it again. And that concept doesn't sound so strange anymore. That we have to get to herd immunity one way or the other. And the fastest way to get to herd immunity with the least number of deaths is to isolate the people at the highest risk in nursing homes and some other people, and let the virus run among the other population, the young and healthy, until we have herd immunity, and then it's over. This is how, over the last 100 years, at least 200 respiratory virus epidemics have ended naturally. They come, they peak, and they end, and the whole thing happens within a few weeks, and that was no different, for instance, in Wuhan or South Korea or Italy. The epidemics ended naturally, like all respiratory virus disease epidemics do. However, and then you have relatively few deaths. However, what happens if you mitigate? People say, well, we want to stop the spread. Yeah, try again. You cannot stop the spread of the virus. You can, at best, slow it down a bit. Isn't that good? Not really. In the end, you need almost as many people to get infected, to have herd immunity, even if the level is a bit lower, have herd immunity. But what happens if everybody mitigates, if everybody wears a mask, if everybody practices social distancing, all things that the vulnerable should do to get protection?
Mm-hmm.
If everybody does the same thing, the vulnerable get infected as much as everybody else.
Right.
Just because everybody does the same thing.
Right.
So the vulnerable have no extra level of protection. More of them get infected, and they are the people most likely to die. So if we are all wearing masks, if we are all distancing, if we are all doing these things to equalize the protection for the vulnerable and for the healthy, we end up with many more deaths. And that is well known. There's no question about that. And the one thing that I don't understand is why people are not thinking by themselves. Why are they believing everything some politician tells them for whatever reason? Wearing masks is not protecting other people in the social settings that we have here. Wearing masks is at best, meaning if the masks are working. If the masks are working, wearing masks is something that increases the number of people dying. That's the first problem. The second problem is, I'm not sure if you remember that term, lockdowns and masks and whatever else is were introduced to flatten the curve.
Oh yeah, of course.
If you flatten the curve, it takes more time. And since the observation of that virus in Spain in the summer of 2020, we know what happens when you flatten the curve for the spread of a coronavirus. It keeps mutating, and it takes about 3 months for the virus to develop a resistant strain, because it needs several escape mutations that need to be acquired successively. And that takes time. So if you're flattening the curve, you're giving the virus the time it needs to develop a resistant strain, one that can spread even in the presence of herd immunity against the previous virus. So flattening the curve not only increases the number of people dying during this particular epidemic, it also incubates the next variant for the next epidemic.
Mm-hmm.
And we have seen that many times. I like the case of Japan, because Japan is an isolated population, not only geographically, but also culturally. There is much fewer people getting in and out of Japan than out of the UK, for instance. And so you see how the epidemic develops within a particular region. And what we had in Japan is we had now, it just ended, the 8th wave. And during this time of the 8th wave, the vaccination increased. So now, on the average in the whole population, everybody has at least 3 jabs. 3. And what happened to the epidemic? Every wave, at least among the last 3, but every wave of death was worse than everything before.
Going all the way back
So
to
we had, even though more and more people get vaccinated, we have more deaths per wave.
So let me ask you a question.
You can draw your own conclusions.
Well, right. I mean, I think there's a couple different ways of looking at it. I have to go look more carefully at the data because you just presented to me today. But I do appreciate the point. You know, the question I have, first of all, is are all 3 of those injections, were they all the original ancestral, or any of them the bivalent?
This is a very broad statistics, but in Japan, the vaccines that were available to the people were no different from the vaccines that were available in Europe and in the United States.
I've written on this a little bit, and my take on it is that I'm on board with pretty much everything you've said so far. My own, the way I look at this, actually, I don't know if you're familiar with the Alec Baldwin, the actor. He's pretty famous, from 30 Rock and a bunch of other shows. And he's got, I think, 3 brothers, and he's got a niece, Haley Baldwin. They're all reasonably famous. And the example I used, Alec Baldwin, is on trial potentially for shooting somebody on a set of Rust. And so we'll just stipulate he's the ancestral version. He's the most dangerous of the SARS-CoV-2. So they're all Baldwins. And so Alec is the dangerous one. He's the original, the ancestral SARS-CoV-2. But each strain that comes along is a little bit less like him. They look a little bit like Alec Baldwin, but not very much. And so the alpha, the beta, the delta strains, there are others, but those are the major ones that came along. They're like Stephen, Billy, and I forgot the other Baldwin. And so they're not quite as dangerous as Alec Baldwin. And so if you're protected, if you have a picture of Alec Baldwin not to let into your house, that's your immune system. They might let some of the other Baldwins in because they're not as much Alec Baldwin. So there's basically some mutation, some flux, some variation from the original Alec Baldwin. And the example, just to strain this example, I apologize, but Haley Baldwin is married to Justin Bieber. She's his niece. She is a Baldwin technically, but she's not dangerous like Alec Baldwin, or even as dangerous as the brothers, because she's a gal and she's pretty harmless. And so I see that as Omicron. It's not quite related to the original strains. So what people have been doing mostly is they're vaccinating against Alec Baldwin when Billy and Stephen Baldwin and I forget the other one, are coming along, and they don't get full protection because it's not Alec Baldwin for whom they have an ID. The police have a picture, and Haley Baldwin, there's no point in even being concerned about Baldwins anymore when Haley Baldwin's the only one around. So I think there's kind of a category mistake in treating Omicron as if it's still coronavirus. You pointed out earlier on that we've had coronaviruses forever. And I had an article in the Daily Skeptic in October. Should we stop treating Omicron like COVID-19? Because COVID-19 is long gone. It's we're 2022, 2023. These are different strains, and I think what we're having is kind of a fallacious look at testing. So we're testing positive for coronavirus. Oh my God, it's COVID-19, but there are other coronaviruses. And I think people keep kind of flipping, leaving this out of the equation. So it's sort of an irrelevancy to have had all these multiple jabs against Alec Baldwin when there's other Baldwins around for whom this does not really adequately cover. I think that's part of the article, the Wall Street Journal was mentioning, about the Lancet, is that natural immunity has been better for all these more recent variant strains because, frankly, there's no real coverage from the original ancestral spike protein jab, injection, vaccine, to these other ones who are not the same version. It's not Alec Baldwin anymore. And again, whichever Baldwin it is, or maybe it's not even a Baldwin at all. It's just it's moved on. And so I apologize for the analogy, but the Japan data, I'm not sure there's huge waves of illness overall in a greater scheme of things to Omicron. I mean, I think it's probably equivalent to a flu, that kind of thing. But as these various waves point in, I mean, certainly to your point, it is an increasing irrelevancy, and certainly not necessarily a benefit to have had extra jabs, extra injections, extra vaccines against something that does no longer exist. The Alec Baldwin version, the SARS-CoV-2, doesn't circulate anywhere on Earth. It's all been gone for a long time, and so we keep, a fair number of them, even the bivalent, we keep injecting against that when it's an irrelevancy at best, and at worst, a potential risk factor for its own separate problems, given that they're risk factors from any vaccine. So I apologize for going off on a little rant there, but I think I'm mostly in line. I think it makes it difficult to interpret data like that because, in a sense, the vaccine is sort of an irrelevancy if it's using the ancestral component.
Okay, I'm not sure if I follow the example or the analogy.
Yeah, I'm
and
sorry.
in general, I don't like analogies because every analogy has its flaws. So if I can argue without an analogy, I will try that. So what we have here is, while a virus is in a population, the population acquires immunity. And if enough people are immune, then the virus has nobody left to infect anymore, and the epidemic is over. So that is, actually, it doesn't have to be everybody. It's enough. I said enough people. So if we are flattening the curve, we are giving the virus enough time to develop enough mutations, several of them, successively, to be able to spread again in the presence of immunity against the previous version of the virus. And then we have something that is essentially a new virus. And so I don't know where that fits into your analogy. One thing that we know is that the virus evolves not only to evade the natural immunity, but also to evade the vaccine-induced immunity. So based on the underlying biology, the effectiveness of vaccines is constantly declining. And that is something that we now have data for, and it's known that even those people who would ignore that in the beginning are now realizing that the vaccines against the old virus variants are not as effective against the new variants anymore.
Right.
And there's a clear biological explanation for that.
Yeah, I agree. Perfect. So let's talk about what you're up to now. What are your efforts? What have you been doing? What should people learn from the situations we've had? How do we try to address the current situation, such as it is? Well, okay, so I'll try to parse that a little bit. Let me go backwards first. What's going on with the COVID-19 response currently? You mentioned a May 11th, I guess, cutoff. What's going on by the U.S. government? What are your thoughts about it? What are the predictions or worries?
Okay, my thoughts first. I think that starting in the late summer of 2020, the government realized, or the governments realized, that they had made a big mistake. It was so obvious at that time. The problem is, if they had in April, on April the 17th, or the days after that in the US, and similar in other places, if they had stood up and said, what we told you 4, 5, 6 weeks ago, that we need lockdowns, we were probably too pessimistic, so we don't need them anymore. Sorry, we erred on the side of caution. Whether that's true or not, but anyway, the government could have said we erred on the side of caution, so let's reopen the country, and we can deal with 4 weeks, maybe 5 weeks of lockdowns. And I think everybody would have understood that. People would have said, okay, it was a new virus. Yeah. Who knows? The problem was that the guidance, and I said that in the very beginning, the guidance from the director of the CDC to reopen the country on April the 17th was not heeded. Somehow, for reasons that I don't understand, the lockdowns continued. And so and after a couple of months, we had major damage done from the lockdowns, from the side effects of the lockdowns.
Yeah, no,
and so it became very difficult for the government to say, oh, we made a mistake, let's reopen. So they were looking for something else.
Yeah.
Then the idea came, let's do the lockdowns until we have a vaccine. Unfortunately, as every epidemiologist would know, a vaccine against a respiratory virus disease comes always too late. Because at the time where you have the vaccine, the variant the vaccine is really effective against doesn't exist anymore because natural immunity has eliminated it.
That's exactly my Alec Baldwin point right there.
So the vaccines didn't work. And now the governments are backpedal. They still know that it was a big mistake what they did. But they're backpedaling slowly, saying, well, we have lots of death, which we originally had from Omicron, but people are dying of a milder virus, and so the deaths are not so bad. Okay, I'm just trying to make the point here that the idea of it's a milder virus, and no, people were still dying until about a year ago. But right now it is also in China. Worldwide, the governments are backpedaling, saying we want to do less lockdowns for whatever reason, and then they come up with something. So they want to get to do what they should have done 3 years ago, 3 years ago, and that is essentially nothing.
Right.
Because to think that politicians today know better how to fight a virus than the human immune system that was developed over a few million years is a bit absurd.
Yeah. So have you heard the recent, speaking of flip-flopping, Fauci flip-flop in the sense that vaccines don't really work, don't really work for respiratory viruses. It was like a couple of months ago, maybe a month ago. It's like, the viruses come in, respiratory viruses come through mucosal tract, and the vaccines are inside, have immunity. They don't really work in essence against respiratory viruses. Did you see that flip-flop, as it were, or admission against interest? Had you seen that one?
Yeah.
All
We
right.
have other diseases that are transmitted through breathing or through droplets, and where vaccines work very well. Smallpox. The difference between the respiratory virus diseases and diseases like smallpox or measles or whatever else you want to come up with where vaccines are working pretty well, is that these vaccines, the other vaccines, the other viruses, they don't mutate. Smallpox didn't mutate all the time. Measles doesn't mutate. So if you have a vaccine, you have a vaccine. Well, the problem with respiratory virus diseases is that they mutate a lot. And so if you have a vaccine, you can hope that there is still some cross immunity between the virus it was designed to work against and the virus that's spreading right now. But it's not more than a hope, and well, usually there is a bit of cross immunity. But that's all what you have with respiratory virus diseases.
Right. Well, I think there's two other differences. I mean, with those measles and smallpox, those are systemic problems that are getting inside your body. So if the vaccine's been inside your body, it's working inside. Whereas the internal injected vaccine is not necessarily going to provide you mucosal antibodies to the same extent as a natural immunity does. Natural immunity, you're going to have more surface contact, and you're going to have more surface preparation for any future viruses of that type, whereas the injection is not necessarily going to have the same ability to stop the initial entry and potentially passing it along.
There is a misconception here, and that is that the whole event happens in the mucosa. The mucosa is the first step of the virus to enter the body, and then it spreads beyond that. If the virus would stick to the mucosa, we wouldn't have the replication of the virus to these huge numbers that in the end can overwhelm the immune system of the vulnerable people. If it were restricted to the nose, okay, you might not be able to smell for some time, but then you wouldn't die from it. You wouldn't die from an infection of the mucosa in the nose.
No, I get that. I'm just saying that it could be that the vaccines against measles and smallpox work better because that is where well, I'll have to maybe rethink my theory, but that's where the major problem happens is systemically. Whereas I think a lot of the people who have the, coronavirus, they're going to have respiratory compromise. It's sudden adult respiratory syndrome. So it's a lot of it's happening on the surface, within the lungs and so forth. The reaction initially within the surfaces. So I don't want to spend a lot of time on that, but I think that is a minor distinction that would maybe bear some examination. But let's kind of carry on a little bit and talk about, because I think we're rounding towards the 3/4 of an hour, and I'd like to come up with some closing thoughts and statements about where you've concentrated since then. Has your voice been heard more or less in the interim? Is there any acknowledgement that you might have been right? And what are your recommendations? So let's do the you story first. What has been the fallout for you?
What I have been working on and advocating very early on and ever since is to fight the comorbidities rather than the virus. We are notoriously bad in treating virus diseases. We have one hepatitis C, and we know why this is a big exception. We have no really good treatments against any other virus. I'm simplifying a bit here. So we cannot treat it. With the respiratory virus diseases, because they mutate so fast, we cannot vaccinate against them. Because it's spreading easily, we cannot isolate. And it's spreading before people have symptoms. So you cannot, this is a big difference to smallpox. Smallpox was not spread before people had symptoms. You would first see the symptoms and could isolate the person. And only then would the person become infectious.
Mm-hmm.
So we know that none of these strategies is very effective. But we also know that if you don't have metabolic syndrome, which is being obese, having type 2 diabetes, having atherosclerosis, having immune deficiencies, there's a whole bunch of conditions. And some of them, and the most common is metabolic syndrome. And metabolic syndrome can be addressed and reduced through nutritional interventions. And people say, well, that never works. People have said that also to masks, that they never work. They couldn't imagine people wearing a mask and accepting that the country is shut down. So I think we could successfully reduce the amount of metabolic syndrome and thereby reduce the amount of death dramatically for all sorts of upcoming respiratory virus diseases. And that is something that I have been working on. We have identified a component, and that is alpha-cyclodextrin, that is known to be effective in clinical trials against all types of respiratory virus diseases. And we have made it from a drug that needs to be is difficult to absorb to one that is easy to absorb, or an intervention. Let's not use the word drug here necessarily. So there are things that at least should be discussed. But that discussion never took place because it was vaccine, 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 and nothing else. And as I said before, lack of discussion means we have lack of science.
I agree with you there.
We need to discuss and be open to look into other options. And so I think what we need to do is to take a serious look into nutritional interventions with substances that are well characterized and known from clinical trials to deal with with at least one of the major cofactors of people dying from COVID, and that is metabolic syndrome.
Excellent. So let me ask you on a personal basis, you had some fame, notoriety, and popularity during 2020 and whatnot. And do you find that people are coming back to your theories? Are they looking back? Are you welcome in the scientific academy? I texted you something showing, ResearchGate, the number you would have hundreds of citations every year from other researchers, and that number's like dropped to 0 in the last year or so. Do you feel ostracized? Have you been ostracized? Is your voice heard? And are you getting any kind of apologies or acceptance for your previous concepts?
Where do you live?
Where do I live?
No, it's a rhetorical question.
Right.
Nobody apologizes, of course. That would be to expect that would be totally unrealistic.
Okay.
The best I could hope for is companies actually being interested in at least having a discussion. But even that doesn't happen. If you do something that is not mainstream, not what the government has expressed they want and are funding, and then the industry is doing it, if there is something outside of that mainstream, it is being ignored.
Right. All right. Well, I'm going to let you have a last word for our audience, but before I do that, I put in my shameless self-promotion here. I'm the author of this book, overturning Zika, which is the last pandemic, or as I say here, the pandemic that never was. And it's on Amazon for people to find and shop and so forth. It's coming out in Brazil shortly. Jay Bhattacharya has commented on it favorably. And I'm hoping, well, I'd love to get your thoughts on it, but I'm hoping that people will look at that to kind of reinforce that the public health authorities are not right all the time. There were a lot of pronouncements. People were told not to have children ever until there was a Zika vaccine. It's been 8 years and counting. No Zika vaccine. People would have been birthless throughout the Americas, throughout the tropics, if they had listened to the WHO. So I recommend they take that with a grain of salt, which is probably not as people have been told, also a huge risk for hypertension, salt that is. Anyway, so would you like to give us a last word to our audience?
Yeah, I have said that many times, that what you just mentioned, we should not necessarily trust our governments. We should actually question them all the time, and we should act. Should take over the initiative. A democracy can only work when people take over the initiative and actively question the government. If people don't do that, the governments, you said, do they come and apologize? No, they do not come and apologize. The only way of doing that is to engage actively in the process of democracy. And in the United States, democracy is always seen as something, yeah, it's in the books. We have the Constitution, so we have a democracy and we don't need to do anything about it. I think that is the wrong approach. We need to do a lot about it all the time.
Benjamin Franklin said, we have a republic. You have a republic. We have a republic if we can keep it. And so it does redound to the fabric of the people involved. And you, dear listener, are one of those people. So you have to keep these things in mind. Thank you, Professor Wittkowski, for your time. You can stay on. We can chat for a minute, but we're going to say goodbye to everybody else. Thank you so much.
Thank you.